Sprint trial was looking in a randomised fashion between lenalidomide single agent and investigator choice single agent. There were a range of single agents that could be used, but again a clear benefit of lenalidomide over the range of investigator single agents that were used. What's interesting with that study is the response rate with lenalidomide, the duration of response with lenalidomide is absolutely identical to every other trial that's ever been done with that drug. So it's very reproducible. About 35 to 40% of people respond, and the duration of response is about 16 months. Absolutely reproducible. What would be really nice if we knew who those patients were, because it's a good drug and it's well tolerated. So R squared, of course, is quite topical in the follicular lymphoma world. So there's a study presented here from the States looking at Rituximab with lenalidomide in upfront mantle cell lymphoma patients. Very high response rate, 52% complete remission rate, so very high. What's interesting though is this is of course chemotherapy-free regimen, but almost 50% of the patients got significant neutropenia, so non-chemotherapy doesn't mean non-side effects. So I think we just need to be aware of drugs like lenalidomide. The toxicity is there, and we've got to be a bit careful I think when we start combining some of these drugs, but very active as a combination. I think the news in the clinic is that there are a number of newer drugs that we're going to have to work out how we incorporate them into clinical practice. And NICE are looking at Velcade, NICE are looking at lenalidomide, NICE are looking at ibrutinib. So I think there's going to be a slight hiatus. We know what we'd like to do, we can't do it yet, but I suspect in a year's time then a lot of the things that we see here will get incorporated into clinical practice.